Hello. Today we are briefly going to talk about esophageal obstruction or choke in the horse. And this typically occurs when feed or another foreign object becomes lodged within the esophagus. And it actually amazes me what a horse can get into and get lodged into his esophagus. I've seen horses with sticks, stones, entire carrots, an entire apple stuck within the esophagus. And so, given the anatomy of the horse's esophagus, there are four main locations where the esophagus turns or it narrows. The things are most commonly obstructed, and that includes postpharyngeal, so right at the entrance into the esophagus, the thoracic inlet, heart base, and at the entrance to the stomach. And two types of obstructions can occur. A primary obstruction is most common, and this is caused by an intraluminal obstruction of feed material or a foreign object. A secondary obstruction is caused by a mechanical obstruction of the passage of feed material due to a lesion or congenital abnormality. And so for clinical presentation with signalment, this most commonly occurs in younger horses when we're looking at the primary cause, and this can be due to competition at the feed, so anxiety for not being able to get enough to eat, so sometimes they'll just sit there and scarf. If the owner comes and feeds late, they'll scarf their feed down, especially if this is a grain or pelleted feed. Thoroughbred foals are also predisposed due to congenital esophageal ectasia. Friesians also can have megaesophagus as well as motility issues within the smooth muscle or the skeletal muscle. And so for predisposing factors, looking at primary obstruction, we just talked about competition, herd dynamics, something that leads the horse to scarfing its food, but also more commonly dentition issues. So either in the young or old horses, problems with the teeth, they're not chewing it properly and it can become obstructed. Other factors include sedation or anesthesia, which can change motility, as well as dehydration or exhaustion. For secondary obstruction, predisposing factors here include a stricture, diverticulum, intra or extramural masses, as well as cysts. And so clinical signs that you'll see when a horse is choked is distress. So this can actually be a fairly painful thing. Something stuck in the esophagus, it hurts, and so they can become distressed because they're in pain. If the obstruction is large enough, it could lead to compression along the trachea, which might be leading them to panic, as well as the fact that they can't swallow anything, so they have a lot of stuff pulling into their throat, which can cause them to then get into the trachea and start to panic that way. Coughing and retching for the exact reasons I just explained. Things are starting to pool in the back of their throat. It can't get into the esophagus, so it ends up in their trachea and they start coughing it. This is particularly if the horse is trying to drink water, trying to clear that out by getting water into their throat, or potentially they're getting a little bit dehydrated because it's been going on for a little while. So that can lead to water getting into the trachea and then having them coughing. Tylocism or excessive salivation. For one, they can't swallow the saliva, so it can't go anywhere but out of their mouth or out of their nostrils, as well as they're going to be producing increased amounts of saliva to help to try to clear that obstruction out. Dehydration, because they're not getting any sort of water down into their stomachs to be able to absorb that. They're also losing quite a bit with the excessive salivation. And then dysphagia, because there's an obstruction there, they cannot swallow. So a very classic presentation is that an owner will call and complain that the horse was fine before they fed. And then they went outside to check on the horse 20, maybe 30 minutes later. And what they've noticed is the horse is now hanging its head low, and they have either white discharge coming out of their nose and their mouth, which would be saliva, or they have a green nasal discharge coming out, and that would be a lot of feed material. And this is typically bilateral, so coming off of both sides. Additionally, the horse's head might be hanging really low to the ground, or they might be stretching their neck out really far. Again, this is incredibly painful for them, so they might be stretching out their neck in order to try to relieve that pain or that pressure on their esophagus. So differential diagnosis include things that you would think of with dysphagia. So botulism, congenital defects. I'm going to highlight rabies here. And so although rabies is not common in horses, when you do see it, they most commonly present with the dumb form, which looks like choke. And so I'm going to highlight it again. The most common presentation for a horse with rabies is to present as or like a choke. And so that always needs to be in the back of your mind when you're seeing a horse for choke, making sure that they've had their rabies vaccination, both for the horse's health and trying to figure out what's going on with the horse, but also for your own and other human health concerns. Other differential diagnoses would be end-stage liver disease, lead toxicosis, as well as plant toxicities that might look like choke or also cause dysphagia. So one of those would be clover toxicity. So clover toxicity leads to excessive salivation. So not necessarily choke, but it might present like that. The owners might think that they are, but you can help differentiate that because with clovers, it's called slobbers or the chewing disease because the horse will be excessively chewing and drooling out of its mouth, but it can't swallow. Another thing to be thinking about would be yellow star thistle, which affects the ability for the horse to prehend food as well as to chew it. And then it also affects the tongue muscles. And so they aren't able to chew it well, but they also can't bring the food to the back of their throat in order to be able to swallow. And if they can get it back there, then they're at an increased risk for choking because they can't chew the food very well. So it's in larger pieces and it can become obstructed. And so one of the ways that you can differentiate between a choke and potentially another toxicity such as yellow star thistle is looking for other things like cranial nerve deficits that the horse might have. As well as with yellow star thistle, the horse might actually put its head further into the water trough because, again, they can swallow. Most of the time, they just can't get the water or the tongue motion to get the water back into their throat. And so they'll try to get it as far as they can into the water trough to get water to flood to the back of their throat so that they can swallow. Diagnosis. So once you go out to the farm, you've done a physical exam, you looked for cranial nerve deficits. One of the things that you might be able to do is actually palpate an obstruction within the esophagus. And so this, of course, needs to occur if it's a proximal obstruction. You're not going to be able to feel anything if it's in the thoracic inlet or distal to that. But if it's up in the proximal esophagus, you might be able to actually feel that feed obstruction. And so my thought question to you then is, which side of the neck should you be able to feel that obstruction? So think back about the anatomy of the horse and where the esophagus is coursing and where you'd most likely be able to feel that. So you can confirm the obstruction by passing a nasogastric tube or using endoscopy. And so most likely out in the farm, you don't have your entire endoscopic tower with you. You're going to have a nasogastric tube. So that's the most likely way that you'll be doing it out in the field. And so once you pass that nasogastric tube, how do you know that you've reached the obstruction? Well, it's pretty obvious. So you might think it's pretty obvious, but yeah, once you reach it, you're not going to be able to push back the obstruction. You're not going to be able to get into the stomach. And typically, a lot of feed and saliva that's been pulling in front of that obstruction is going to come pouring out of your nasogastric tube. And so if you are the type of person that likes to use your teeth as another appendage, then that can be a very unpleasant experience for you, as well as I won't go into all the mentioning, of course, of the human health concerns of using your mouth for passing a nasogastric tube, but that could definitely be an unpleasant experience. So once you've confirmed that he is choked and where the choke is, you're going to end up treating that by using gentle pressure with your nasogastric tube, as well as lavaging with some water. And so the key here is to make sure that your horse is heavily sedated before you do this. And the reasoning behind this is once you start to pump water, where's that water going to go? Well, if the horse is still obstructed and it hasn't broken up yet, it's going to go exactly where all that saliva was heading, out the horse's nose. So water is going to start pooling out of the horse's nose, which can be a very unpleasant experience for them. If you think about it, it burns quite a bit if you think about swimming and getting water into your nose. So the horse, if they're not heavily sedated, their reaction is going to probably be to throw their head up and potentially start to panic. This can become dangerous for you, especially if you are in the way and you end up getting bashed with their head, as well as other people around them. It can dislodge your nasogastric tube, which is actually very frustrating because now you've got a mad horse that you have to repass the nasogastric tube on. And the most important thing beyond all of this would be the increased risk for aspiration pneumonia, because as soon as they start to throw their head up, any of that water feed saliva that's still in the back of their throat is going to go down into the trachea. And so heavy sedation, there's lots of different combinations that you can do. Ace-promazine is a common one that is used, and the reasoning behind that is that it is thought to help relax the esophagus to be able to relieve that obstruction. Be careful with this in stallions. Review your pharmacology if you don't remember why. But you never want to use acepromazine by itself. It's not going to give you enough sedation. It's not going to give you any analgesia for these guys. So you want to combine that typically with detomidine and bitorphenol, and that'll allow you to get that anesthesia effect that you want, or that sedation effect that you want, and the analgesic properties. And so if you look at this horse in the picture, what you can see is his head is almost to the ground, and that's where you want him. And of course, they have the application of the twitch to also help promote some calmness or some sedative types of properties for them. So once you've got the horse adequately sedated, nasogastric tube is passed, you start to lavage with some water, gentle pressure, and see if you can gently push that obstruction, break it up down into the stomach and get it cleared. Never, ever use mineral oil to lavage or try to lubricate this obstruction. This can lead to a fatal aspiration pneumonia if they get mineral oil into their lungs. I've actually heard of veterinarians who have been sued and taken to the board for using mineral oil in horses that have died from aspiration pneumonia from it. So never, ever, ever use mineral oil. Water by itself, that's it to lavage these chokes. Prolonged chokes can lead to erosion or ulceration of the esophagus and increases the risk quite dramatically or extensively for aspiration pneumonia. So if possible, refer horses that do not respond to their initial management, because there's lots of different things that we can do in the referral center that's more difficult to do in the field. And one of those is that we can confirm that the choke with endoscopy. And not only does it's choked or where it's choked, but also to see if there's anything complicating it. So I've definitely had chokes where there's feed material on top that we get through, and then all of a sudden at the bottom we see that there's a huge apple that was actually the initial problem, and then feed just packed on top of it, and that would be very difficult to try to clear into the field. We can also use the endoscopy to kind of help pick things away, especially if the esophagus is already getting irritated and starting to see some ulcerations. We can try to break that up a little bit more gently without using a nasogastric tube. If that doesn't work, the next thing that we can use is general anesthesia. And so this has a couple of different effects. One, it helps relax the horse because they're under anesthesia. It helps to relax the muscles of the esophagus to make it clearer to be able to get the obstruction out, as well as it helps us to protect the airway so that we can use an endotracheal tube that's cupped. So if we're using water, we don't have to worry about all of that going into the lungs. And then we can get a better effect onto gravity, especially once they come into the referral center. Most of the time they're worked up. They're harder to get sedated. They've had a lot of sedation already, and so sometimes just going to general anesthesia is a better option for them. Very rarely, these will require surgery to correct via an esophagostomy. We try to avoid these whenever possible, as the esophagus lacks a serosal layer, and so it does not heal well. And complications of surgery include infection, development of strictures at the surgical site, which leads to then a recurrence of obstruction. So we do try to avoid this, but occasionally that is the next step that we'll have to take. So management of these cases post-choke. Well, the great thing is a lot of these resolve before you even arrive. And so at this point, no further treatment may be needed. If you pass a nasogastric tube, confirm the fact that you can reach all the way into the stomach, that might be it, especially if it's an acute choke that's happened. The owner saw it happen. They cleared it within maybe 20 minutes on their own. Then most commonly we'll just tell the owners to watch for signs of aspiration pneumonia. Give them all of the keys, looking for fevers, any signs of coughing, decreased appetite. Make sure that they still are very aware of watching for aspiration pneumonia. If by chance they're still obstructed when you get there and you get it cleared, then most of the time I will treat with sucralfate to help for any esophageal irritation that might have occurred. So this allows them to have a little bit of Band-Aid, especially if I've seen a little bit of blood within my nasogastric tube. At that point, if you're seeing any blood, I should mention, and it hasn't cleared, refer them at that point because you don't want to lead to any more irritation of the esophagus. But if you saw a little bit and then they cleared it out, definitely put them on sucralfate. But that's something that's a fairly benign treatment that will help to let the esophagus heal. Banamine is another thing, 2 to 3 days worth of Banamine to allow them to have an anti-inflammatory effect. And then I typically keep them off of feed for about 12 hours and then recommend soft feed for 24 to 48 hours after that, again, to allow the esophagus to have some time to heal. And so if you look at the picture over on your right, and that's an ultrasound of a lung that I did on a patient 24 hours post-choke that wasn't treated with antibiotics. And so that's a very, very large lung abscess. And if we think about what type of bacteria that horses will get when they have an aspiration pneumonia, it's a mixed population, including anaerobes. So when horses develop aspiration pneumonia from choke, it's typically a fairly extensive disease that can often lead to their hospitalization, multiple different types of antibiotics, and it can be deadly. And so aspiration pneumonia is considered the most common complication after choke. And so with these guys, I do recommend using antibiotics for them in the field after you relieve the choke to be able to help prevent that. You'll want to refer for any repeat offenders looking for other sorts of issues that might be causing them to choke. I'm assuming at this point that you guys have done a good dental exam, making sure that that's not a factor. So we're looking for other sorts of issues that might be a diverticulum or an abscess, something that might be leading them to choke more frequently. If all of this rolls down to the fact that they are scarfers, they are eating very quickly, then prevention might be trying to figure out ways to slow them down. So this could be more frequent meals throughout the day instead of feeding once or twice daily. It could include this lovely puzzle bucket, which mimics very closely to what they have in dogs, but forces them to slow down because they have to really work into those circles to get food out. Some people will go a little bit of a cheaper route or a little bit more of a practical route by just putting big bricks into the feed troughs to help them slow down because they have to, again, work around those blocks or bricks to get around that. Also, the usage of a hay net can help slow them down and give them something to do more throughout the day instead of scarfing their food in one meal.